Welcome to today's episode of the HealthTree podcast for multiple myeloma, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. We'd like to thank our episode sponsor, Takeda Oncology, for their support of this program. Before we get started on the show today, I'd like to make you aware of our HealthTree Myeloma Coach program. Our coach program includes over 200 experienced myeloma patients and caregiver volunteers who can help you navigate your multiple myeloma with one-on-one support. You can use one or multiple coaches, and you can select a coach that looks right for you. Coaches have experience on specific issues like finance or other topics, or in specific myeloma therapies like CAR-T or stem cell transplant. They can work with you by phone, on the computer, or in person if they live in your area. You may have noticed also that we are moving over from myelomacrowd.org to healthtree.org/myeloma, and we hope you can use that new link for all of our support programs. So if you'd like to find a coach, you can go to that URL and then look in the menu under apps and programs. Now on to our show. We know that a large percentage of multiple myeloma patients develop kidney issues, and this show is dedicated to understand the management of kidney concerns better with the help of Dr. Natalie Callander from the University of Wisconsin. Dr. Callander, welcome to the program.
Thanks very much. My pleasure to be here.
Yeah, so nice to have you. Let me just give you a little introduction for you before we get started. Dr. Callander serves as Director of the Myeloma Clinical Program and Interim Director of the Bone Marrow Transplant Program at the University of Wisconsin. She's also Professor of Medicine, Vice Chair of the NCCN Myeloma Committee, and attending physician at the William S. Middleton VA Medical Center. She's also a DOT leader of the Myeloma Disease-Oriented Team and chair of the Bone Marrow Transplant Clinical Trials Network Intergroup Committee. She graduated magna cum laude from Yale University and has been named as one of the best doctors in America list for over a decade. She's also received the Chuck Koval Award for Excellence in Myeloma from the Leukemia Lymphoma Society. She's listed as one of Madison magazine's top doctors in hematology and has won a Patient Experience Physical Champion Award from the University of Wisconsin for multiple years. Dr. Callander leads many clinical trials that have led to approvals for myeloma drugs. So we're very grateful for your efforts in growing the myeloma arsenal for patients. And impressively, on your CV, I saw that you served as a major in the U.S. Air Force for almost a decade while you were doing your residency. So I'm just so impressed with that, and thank you for your service. It's amazing.
So, yes, well, I am happy to be here to talk and answer any questions. This can be a little bit complicated, so, please stop me, Jenny, if what I'm saying doesn't seem to make a lot of sense.
Yeah, I think we'll start with basics. So basically, can you explain what is kidney disease?
Okay. Well, the kidneys are a paired set of organs that are basically sort of mid-back, if you want to think. They're behind the abdomen, if you want to think of it that way. And, of course, their job is actually complex. They are there to regulate water. They are also to regulate sodium and potassium. They have a major impact on blood pressure. They also supply an important hormone called erythropoietin that is essential for red blood cell production. So they are really very, very critical organs.
And what happens when the kidneys get damaged? Like, how would you define chronic kidney disease?
Yeah, so there's a very strict definition of what that is. Now, kidney function is often measured by what's called glomerular filtration rate, and that comes from a part of the kidney called the glomerulus, which is kind of like a squiggly little bit of membranes where exchange of wastes and fluid take place. And the formal definition of chronic kidney disease is if your function is reduced roughly by a third for more than 3 months. And so that translates, if you're looking at your labs, into a reduction in glomerular filtration rate, typically under about a 60 milliliters or cc's per minute, which is a lab that you can usually find, or maybe it's calculated in your chart.
Mm-hmm. And is there a difference in myeloma? Is it considered chronic kidney disease, or is it just kidney disease?
There are many ways the kidney can be affected when you have myeloma. And roughly speaking, about 20% of people, when they first get diagnosed with myeloma, have some sort of kidney disease. And you can split it up into a number of different problems. So one problem, or one group of problems that people can get with their kidneys related to myeloma, is directly related to the abnormal proteins the myeloma cells are making, so the immunoglobulins. And probably the most common problem is something called cast nephropathy. And that is a term where the light chains, either kappa or lambda, are so high in the bloodstream that as they are passing through the blood that is being filtered in the kidney to remove the waste products and water, those light chains start to accumulate and literally clog up these tubules that are there to help remove water. And so you can get sort of a clogging. There's also something else called a monoclonal immunodeposition disease, and this is where the monoclonal protein that the myeloma cells are making actually sticks to parts of what's called the glomerulus and cause problems that way. That's a little bit more rarer. And of course, some people with myeloma also have amyloid that ends up in the kidneys, and that ends up kind of causing a lot of potential destruction of some of these very, very tiny and important components in the kidney. And then there are problems that can occur that are not related to immunoglobulins, and that includes things like having high calcium can be harmful to the kidney. If you get very dehydrated, that can be harmful to your kidney. If you get a bad infection, and every once in a while we see people who have myeloma that's actually growing into the kidney, but that's relatively rare. And then finally, there are some other sort of immune-related disorders that can be sort of accompanied by the myeloma, things that lead to what's called glomerulonephritis, where there's actually sort of inflammation of this very important component of the kidney, and that can cause things like high blood pressure and occasionally some blood in the urine. So there's a number of different ways that the kidney can be affected.
And just generally speaking, a lot of people who have, maybe they already had chronic kidney disease from things like diabetes and high blood pressure. Do you want to just kind of talk to that before we jump into all the myeloma-specific pieces?
Well, I think it's very important if, for example, if you are newly diagnosed with myeloma and you know, based on perhaps you've had annual visits in the past with a primary care physician or provider, and you know that your kidney function was never abnormal, that's a very important piece of history to share with whomever is taking care of you. Sometimes a person comes in the door with kidney dysfunction, and we will not be sure if part of that dysfunction is related to high blood pressure or diabetes. And some of the different types of problems that I just sort of listed there that can happen in myeloma, more and more we do recommend people have a biopsy of the kidney, because sometimes it's not clear exactly what's going on. And disorders like diabetes and high blood pressure can actually cause some scarring of the kidney that may not be reversible. So I think it's very important to try to figure out what might be a component directly related to myeloma that may be treatable and may be fixable versus something that was there at baseline. So often a kidney biopsy can be very helpful.
And that would be part of your myeloma diagnosis workup, I guess, is what you're saying?
Yes. I mean, I think... Well, excuse me. I mean, sometimes, and I've seen people in this situation where, you know, they come in with a creatinine. A creatinine is one of the measures of kidney function that we use. There's really sort of two that people look at. A creatinine, basically, the higher the number is above 1, usually that sort of corresponds with a decline in kidney function. And then there's also something called blood urea nitrogen, or BUN, or some people pronounce it BUN, that is kind of looking at the filtering capability of the kidney. So if a person walks in the door and their creatinine and BUN are elevated, part of what is your job as a myeloma provider is to try to figure out how much of that is perhaps new and old. And sometimes it's very clear that a person probably has just that cast nephropathy or just an overwhelming amount of light chains that's causing the problem. But I do think sometimes we're surprised, and that's why I think a kidney biopsy can be very, very helpful.
Yeah, okay, that's so interesting. I didn't know that was part of a myeloma workup if you had kidney issues.
Well,
so
I think it's,
to know.
Yeah, you could really be surprised. I think previously, a number of years ago, I think there was more reluctance on a part of a kidney specialist or a nephrologist to consider a biopsy. But I think over the years, more and more people have realized that this is actually kind of a very helpful thing to do.
And what percent of patients do you see walk in as a newly diagnosed patient who have kidney issues or advanced renal disease?
Yeah, as I mentioned, it's around 20%. There are some people. Yeah, there are some people, but unfortunately, over the years that people are living with their myeloma, you can develop kidney problems later on. And sometimes the nature of the problems that you have with your myeloma changes as well. But it's the rough number is about 20% have some kidney issue that needs to be addressed, and there are a percentage of people who come at the time that their myeloma is diagnosed who appear to need support with dialysis right off the bat.
Okay, and what percentage is that? Do you know?
Oh, I would say it's about.
Have a feel for.
Yeah, I would say it's about 5%.
Okay.
And often they are people who may actually have some underlying kidney problems to begin with, or somebody who, for whatever reason, it took a relatively long period of time to make that diagnosis of their myeloma.
Yeah, so interesting. Are there any other symptoms that can indicate kidney disease beyond the lab values, like your,
sure,
that you might notice?
Mm-hmm. Well, so sometimes there are different symptoms in different situations. So if a person has high calcium, sometimes that causes symptoms like increased thirst. Occasionally, people will have abdominal pain and constipation related to that. So those can be tip-offs. There are some times where people come in, and I ask people this specifically because often people do report this. We ask, does your urine look foamy or bubbly? And that can be a sign that you have very high levels of protein in your urine, of those light chains. So that's something that we ask. Sometimes people will say that they are having some changes in the color of their urine, that it looks a little dark like Coca-Cola. That sometimes can be associated with some specific kidney problems. But many times people come in and actually feel okay. I mean, they don't really have a specific issue that we would say, aha, this is related to your kidney problem. Now, people who have very severe kidney failure, which is fortunately really a minority, sometimes they come in and have gotten into a situation where they're nauseated or vomiting, or they're confused because waste products are building up in the system. But fortunately, very few people come in the door with that.
Mm-hmm. It's not as advanced as that. Interesting. Mm-hmm. Yeah, I think that might have been one of the reasons that I went in to, well, not the nausea or confusion, but one of those others, just to get tested. So interesting. So you talked about the labs and the BUN and the creatinine counts. Are there different counts for the African American community? Because when I look at my lab, sometimes in my chart, it'll say that there's kind of like a difference between the EGFR values? I can't remember.
Yeah, estimated glomerular, which stands for estimated glomerular filtration rate. So for many years, what was done in labs was sort of a calculation where patients who are African American will tend sometimes to have a little bit higher creatinine, and this was sort of factored into an estimation of what the estimated glomerular filtration rate was. And what was sort of happening as a consequence is that particularly if patients, and this is not related so much to myeloma, but if patients were African American and waiting on, say, a kidney transplant, they were being unfairly having an overestimate of how good their kidney function was. And so there was actually a task force set up in 2016 to try to address this problem. And there is a equation out there called the chronic kidney disease EPI or CKD EPI, and this is based on looking at GFR based on sex, age, and level of creatinine, and there's no factor of ethnicity, and that's considered a more accurate way to do it. There's an even more accurate way to measure GFR if that's important, measuring something called cystatin C that can be done. That tends to be done more by nephrologists. We don't do that much in myeloma, but there really was a time when the calculations that were used were sort of overestimating the GFR in patients who are Black, and I think that's changing more and more, which is appropriate.
Okay. And are there other factors? Well, okay, so we talked about how kidney disease is affected by myeloma. You walked through that very well, and other factors that can contribute to it. Are certain myeloma patients more prone to kidney disease, like let's say you have light chain only myeloma, or you have IgG kappa myeloma, or IgG A, or genetic factors?
Yeah, there has been some association with the type of monoclonal protein that is made and the development of kidney issues. So there has been, so as many of your listeners may know, that the most common type of protein that a person makes with myeloma is IgG kappa, but a fair number of people will make an IgA monoclonal protein, and IgA has been associated with a somewhat higher risk of having kidney problems. And of the two types of light chains that a person can have, kappa and lambda, lambda has been associated with a higher risk of kidney dysfunction, but it's really quite relative, Jenny. It doesn't mean like, okay, if I have IgA lambda multiple myeloma, I am guaranteed to have kidney problems. It's not that exact. It's just more of a tendency. So, and certainly people can come in the door with IgG kappa myeloma and have very severe kidney dysfunction. So it's sort of all kind of relative, not absolute, if I can say it that way. One thing I would want to talk about just in terms of other factors, and probably something that many people listening know, there are a number of medications that we actually try to get our patients, if they are having any sort of renal kidney issues, to stay away from, and those would be drugs like what are called non-steroidal anti-inflammatory drugs, and those would be things like ibuprofen or Motrin or Aleve, which is naproxen. Those drugs can potentially cause some kidney dysfunction. There are some other blood pressure medicines that sometimes you have to be a little bit careful with, what are called ACE inhibitors. Those are drugs like lisinopril or enalapril sometimes can have a chance of causing some kidney dysfunction. So that's another thing that we try to do when a person comes in the door and we're trying to look at their kidney function. Along with those two classes of drugs, sometimes people come in and they're on big doses of a diuretic like a water pill, maybe hydrochlorothiazide to control their blood pressure, for example. And those are the kind of relatively easy things to do that can make a big difference to stop them and help improve somebody's kidney function.
Yeah, and so NSAIDs, instead of having Aleve or those types of things, you typically recommend something like Tylenol or what do people? So yeah.
I certainly, I mean, there are situations, and all of this stuff is kind of relative. So there are times the non-steroidal drugs turn out to be quite helpful for bone pain. But there are definitely people, particularly those who have an abnormal creatinine, who probably are better off staying away from drugs like that and thinking about some of the alternatives like Tylenol, for example.
And some of that can be like pre-long-term use. Like let's say you had a lot of pain for some other cause, or even myeloma you didn't even know was myeloma, and you're taking it all the time. What you're saying is that can end up damaging the kidney more than you want it to, so stay away from those.
And then there are sort of prescription-only non-steroidal drugs that are used sometimes for arthritis. Like, for example, there's a drug called Mobic that sometimes people are which is the trade name for a drug called meloxicam. Sometimes people, for example, if part of getting to the diagnosis of myeloma, somebody thought, for example, you were having bone pain from arthritis, they might have had you on that kind of drug for a while until they know the diagnosis. So that can certainly be quite a harsh drug on people's kidneys, and one that we would try to stay away from.
Yeah, okay, interesting. So if you have a newly diagnosed patient walk in with some kidney issues or damage, how do you handle that
Sure.
when they're first diagnosed?
Well, what we try to do is, since, as I mentioned, the most common reason they're going to have kidney dysfunction is they're going to have these light chains that are clogging up the kidney. So most people think that the fastest you can bring down those light chain levels is the best. And historically, the drugs that we've used the most would be steroids. I mean, this is a situation where dexamethasone, even though it is not something that anybody wants to stay on for in big doses long term, can be very helpful if given for a couple of days. Bortezomib tends to be a very useful drug in this situation. You can also sometimes use daratumumab. Those last two drugs do not need to be adjusted for creatinine, so we certainly like to use them. Older approaches include using the drug cyclophosphamide, which is an old drug that's been used for myeloma for many years. It has been a little bit controversial. There have been some centers that have done what they call plasmapheresis, which is a treatment to try to remove protein from the blood. It is not really clear that is helpful. It's probably not as helpful as just making sure that a person's light chains are coming down from chemotherapy. But there are some places that still do that. And there has been an attempt to try to make the plasmapheresis more efficient at removing those light chains. But those processes usually only remove a minority of the light chains. You still need to have some sort of effective chemotherapy going on.
Mm-hmm. So treating the myeloma right up front is kind of your most critical.
It's really
issue.
critical, and what we always try to do, particularly if somebody is coming in right off the bat needing dialysis, is that's really a goal to see if we can get them off. And we don't all the time, but you can very often get a person in a better situation by doing some aggressive chemotherapy. One of the things that I certainly like to do is check their light chains relatively frequently. So we are hoping to see at least a 50% reduction in a situation like this, in a couple of weeks, just so that we know that we're on the right track and giving the kidneys every possibility of recovery if they can do it.
Yeah, that's a good question. So can kidneys recover after that type of thing?
They can. And, one of the things that's been gratifying about autologous stem cell transplants is we have absolutely seen people who have been on dialysis up until they have their stem cell transplants, and then following the transplant improve and are able to get off dialysis. I would love to tell you that is the majority of people, but it is something that can happen, and so kidneys do have the capacity to recover. So we definitely continue to try to make sure if a person has really significant kidney dysfunction that we are doing everything that we can to put their myeloma in remission so that it would give the kidneys the maximum opportunity to recover.
Yeah, okay, great. So, you mentioned stem cell transplant, so it sounds like it makes things better. There's nothing that would preclude a kidney, damaged patient from getting a transplant, correct?
Well, we do. This is not true of every center, but most places are pretty comfortable doing transplants in people who are on dialysis. So we do that, and basically because we believe that a transplant is a good way to control somebody's myeloma. Now, you have to have some experience doing this because it takes some scheduling. And we're talking, primarily about people on hemodialysis. But we tend to use somewhat lower doses of the drug melphalan, the one that's used for transplants in general, and we have to time the dialysis around the chemotherapy. But it is widely accepted that you can do a transplant even if you're on dialysis, and like I said, we know that a portion of those patients may recover. But the other thing that can happen is there are times when we've had patients who eventually go on to a kidney transplant, and something that, of course, would be done only in a sort of a select group of people, but it is a possibility for a person whose kidney function doesn't recover even though they're now in remission.
Yeah, that's so interesting. I have some friends who are dealing with that right now,
Yep.
and emailed in some questions, so we'll wait for that at the end.
Okay.
But we were going to cover that.
Okay.
So how about drugs that are harder on the kidney that are for myeloma care?
Yep. So usually the drugs that are sort of top of everybody's list that you have to be a little careful with are the immune modulatory drugs, IMiD drugs, and that would be drugs like lenalidomide and pomalidomide. And pomalidomide lenalidomide for sure is cleared through the kidneys. And so it is a drug that we will use in people even on dialysis, but you have to use typically very small doses. As many of you know, that the sort of starting or top dose of lenalidomide can be 25 milligrams a day. In people on dialysis, we often do 5 milligrams, maybe one dose after dialysis, or even 2.5 milligrams after dialysis. Just very, very petite doses. Pomalidomide is labeled as not requiring renal adjustment or dose adjustments downward. I would say, in my experience, that it is also a drug that we like to diminish in terms of doses. That 4 milligrams, which is, again, the top dose, is something that I think most people with kidney dysfunction actually don't tolerate very well. So we'll usually start at 1 or 2 milligrams. Carfilzomib is also a drug that is not renally cleared. There have been, this gets a little bit controversial depending on who you talk to. Carfilzomib has been implicated in some reports as actually causing renal failure, but I think that is a very rare situation. It is a drug that has a track record of being given to people on dialysis. If somebody is having some heart-related issues like heart failure and they're on dialysis, it can be a very, very tricky drug to use. So that would be one that we would be pretty careful about giving. Some of the newer drugs probably don't need renal adjustment. For example, belantamab looks like you can probably give that with a low GFR. Selinexor, I think there's a little bit less of a track record for that, but there, almost every drug that we use, if you are very careful in the dosing, you can use it, but it really takes just I think a lot of caution, I would say. And then, of course, as I mentioned, steroids are something that often can be given pretty easily in people who have renal impairment or on dialysis, as long as it's not causing a lot of fluid retention.
Interesting. And what about the newer immunotherapies like CAR-T and bispecifics and things like that? What do you see there?
There is more and more data that for CAR-T transplants that people with kidney dysfunction can go ahead and have a CAR-T. The lymphodepleting chemotherapy tends to contain a drug called fludarabine, and fludarabine absolutely has to be reduced and in some cases omitted depending on how much kidney dysfunction a person has. So that's one consideration. But I don't think anybody believes that the actual process of giving somebody a CAR-T is going to cause kidney problems unless, of course, there is a complication like a bad infection. I think there's less knowledge right now with the bispecifics. Those particular patients were largely excluded from the trials if they had a GFR under 30 or 45. But in the lower ranges, they seem to do okay with it. So, and I would imagine that some of the other drugs, I mentioned daratumumab doesn't seem to have any renal toxicity. Isatuximab we'd also put in that category. Elotuzumab also.
Yeah, monoclonal antibodies you're seeing just fine.
They seem to be fine,
okay.
Yes.
Okay, that's great. Well, I know that's interesting. I want to jump to a question later, but maybe we talk about it now. You talked about clinical trials, in CAR-T that patients may have not been able to join that. Are there a lot of trials that exclude kidney patients for that particular reason?
Yeah. There absolutely are, and there's kind of two cut points that are used often. So in some clinical trials, if a person has a calculated GFR, glomerular filtration rate, under 60, they are excluded. There are other trials that let that number be a little bit lower, under 30, or excuse me, as low as 30. There are very few trials that will either take a person who is on dialysis or having a GFR that's below 30. And, often that's because some trials are looking for toxicity signals, and they're very nervous about having somebody who already has some kidney dysfunction on it. If the trial is something perhaps sponsored by a drug company, again, same thing, they're very interested in avoiding toxicity, and so they sort of see that as an exclusion. But it makes it very hard if you are a person who would like to go on a trial, but your kidney function isn't the best. It can be quite difficult to find one.
Okay, well, clinical trials, I understand the concept of wanting to get everything tested in a certain way and having a consistent patient base and all that, but sometimes it gets challenging for patients who are trying to join these clinical trials.
No, I mean,
they have something knocking them out.
Yeah, I mean, every once in a while there are some trials that are specifically designed, but they've been tough. So years ago, they ran a trial looking at, trying to figure out the right dose of lenalidomide or Revlimid in people on dialysis or with kidney failure, and they actually had kind of a hard time getting enough patients to be on the study. Because it can be a unique population, and then sometimes, particularly early on, if people are coming in and they're having very bad kidney dysfunction, they're also having other problems that are just making it hard for them to go on trials. Maybe their counts are very low, or there's other factors there. So it is something that it's been historically and actually in reality very hard to find trials for people who don't have kidney function at least better than that 30 cc's per minute calculation.
Yeah, that's so interesting. So you talked earlier in the show about kidney disease that's diagnosed at the time of diagnosis, where you try to knock it down. But you also said that kidney disease can be developed over time, over the course of certain myeloma therapy. Can you explain how that works and what patients look for and how it's treated?
One of the best things that's happening in kidney treatments is that many people are living longer and longer and longer, which is great. And one of the things that I think we've learned now over time is that when a person starts to have their myeloma relapse, it doesn't necessarily have to be the same way it did before. And in particular, sometimes people who had an M protein, a very large monoclonal protein, IgG or IgA, at the time they were diagnosed, when they relapse, sometimes their myeloma cells then choose to only make light chains. And so occasionally we'll see, because perhaps maybe all that's being followed is, say, a serum protein electrophoresis and maybe not light chains, a person will end up relapsing and now have kidney problems that are related more to the fact that they've got very high levels of light chains that they didn't have before. So it's always, I think, everybody hates collecting a 24-hour urine test. Sometimes it can be very helpful to have that information, particularly at a time that a person's myeloma might be getting worse. The other thing that happens is sometimes it becomes very apparent later on that a person is actually developing some amyloid too. And that might be a situation where a person starts losing very large amounts of protein in their urine. That can be something where you can see a drop in a person's albumin in the serum, which is a normal protein, and in amyloidosis it can sort of slip into the urine very quickly. So that can happen later on where it wasn't apparent at the time of diagnosis. So those are a couple of instances that we can see.
And for people who don't know what amyloidosis is, do you want to just describe what that is for a minute?
So there's a whole spectrum of different disorders that involve plasma cells, and by far the most common one is multiple myeloma that tends to have things like anemia and bone problems related to it. And then there are more rare disorders, one of which is amyloidosis. And amyloidosis, the difference really with myeloma is there is abnormal protein being made by plasma cells, but what happens to that protein is quite different. So it gets sort of, there's a technical name for this, it becomes folded into what are called beta-pleated sheets. But the basic concept here is that protein gets deposited in different organs, And that's what causes the problem. So it's not that you have so many plasma cells that they're kind of overwhelming the bone marrow, as you can see in myeloma. It's really the stuff that's getting deposited in organs that causes problems. And so people will come in, again, with kidney dysfunction, but they also can sometimes get this amyloid deposited in the heart, and that can cause a very specific type of heart failure where the squeeze is okay, but the heart becomes very thickened. Sometimes people with this disorder can have nerve problems, so they can get numbness and tingling. The amyloid can sometimes be deposited in very odd places, lymph nodes. Occasionally it's seen in the tongue. And so, again, it's not so much that people walk in with bad anemia like they often can with myeloma, but it's more where this protein is getting deposited. Now, it's treated often very similarly to myeloma. A lot of the same drugs we use for myeloma we'll use in amyloid, but there are some very specific things that you have to watch for people who have amyloid as their primary problem, particularly if it's involving the heart.
And if you catch it early, you can sort of reverse some of the conditions,
yes,
right?
I think
but
that's one thing absolutely. That's one
mm-hmm.
thing we've learned over time, and there was an era where it was sort of thought, okay, the amyloid, particularly if it was in the heart, is just going to sit there and never get better. And I would love to tell you it's in every patient, but it's not. But in a substantial number of people, if we start treating them and we control the production of that amyloid protein, it will gradually improve in some patients. And one of the things that people are excited about is that there may be some drugs on the horizon that could help reverse some of those deposits. So I think people are very excited about that.
Oh, that is wonderful. Okay, that's good news and nice to hear. Okay, can we talk about kidney transplant for a little bit?
Yes.
What's the process to get on the list for a kidney transplant, and what's the criteria?
Yep, I think every institution that does kidney transplants probably has a little bit of a different take on this. And certainly I think what's happened over the last 15 years that's made this come up more often is several things. Number one is that our ability to get a person's myeloma into a complete remission is a lot better than it used to be. So that's usually a criteria that kidney transplant centers will want you to achieve. They'll want you to say, okay, is your patient in a complete remission? Secondly, what they're looking for is how healthy is the person in general. So if somebody has had kidney dysfunction, bad enough to need dialysis, but they're also having heart problems and they're also having lung problems, those patients are typically not going to be accepted for transplant. So if really the kidneys are the kind of isolated medical problem, their myeloma is now in remission, and some centers will have kind of a cutoff for how long they want that remission to last. In other words, some centers will say, well, we want it to be a minimum of 2 years or something like that. Now, this changes a little bit, at least in our center. The pool of related donors, that is living related donors, and meaning somebody in your family or even a friend or living unrelated donor who comes forward and says, yes, I would be willing to donate a kidney. I think that pool is a lot bigger than it used to be, so that has also opened up the opportunity. And so we have had over the years, I wouldn't say it's tons, but we certainly have had people go through kidney transplants. One of the things that gets a little bit difficult is, particularly if a person has kidney failure but they're still able to urinate, sometimes it's very hard to tell for sure that they're in remission, and occasionally we have had people who have gone through a kidney transplant. Now that urine, that protein that they were losing, it's sort of staying in their blood system, and now we can tell that they aren't in remission. So we have had the experience as well of having to treat people who've been through a kidney transplant, treat them again for myeloma, but again, as our drugs have gotten better, that's become more possible. So we have several patients who have had a kidney transplant, had their myeloma come back some years later. Now they're back on some treatment for their myeloma, but the transplanted kidney is doing fine.
Okay. Now, when you say you have to be in complete remission, by what criteria is that? Is that
right.
You're not talking about MRD negativity or anything like that?
You're just talking
about...
Right. Usually it's been things like a complete remission, meaning you can't find a monoclonal protein in the blood, and many, at least for example, our program would ask that you have a bone marrow biopsy that also does not show any evidence of myeloma, and some places will ask for a PET scan. But like I said, there aren't hard and fast criteria that are being published nationally at this point, and there's still relatively small numbers of patients who are going through this. But like I said, I think there definitely are people out there who have gone through a transplant and done so successfully. But one of the things that you do have to be prepared for is there may be a situation where you will have to treat somebody's myeloma again, and then you have to take into account how do you protect that transplanted kidney, because typically those patients are going to be on immunosuppressing drugs to protect the kidney, so it can be a little bit of a delicate balance.
Yeah, I don't understand the only transplant process I understand is really stem cell transplant and allo transplant, when you're getting GPHD or things like that. In that scenario, do you have issues like that in the kidney world when you're doing kidney transplant?
Yes.
Is that why they're on the immunosuppressants?
Yep. So for organ transplant, what you are worried about is typically it's the recipient can have immune cells that attack the new kidney. So that those kidneys in general aren't coming in with a lot of abnormal cells from the donor. But the recipient can decide, hey, this is not my original kidney. This is something that I need to reject, and so they can, in turn, send immune cells that can get into the kidney and really harm it. So that after a kidney transplant, people are given usually a cocktail, that's the term they will call it, of immunosuppressing drugs, usually an oral drug like tacrolimus, but often antibody drugs that are basically designed to knock down T cell function, and they're often given some steroids. So I think, sometimes what we have noted is that those immunosuppressive drugs that they're on to help protect the kidney can actually have probably some degree of effect against the myeloma itself. I wouldn't say it's, completely transferable that you'd say, oh, that's perfect treatment for myeloma, but there probably is some potential benefit towards myeloma. But one of the things that they will do in a renal transplant versus what we do, say, after a donor transplant for a blood disorder, is they will stay on those immunosuppressive drugs often forever. There has been some move to try to cut down on maybe not making it a lifetime commitment, but that is much more the practice than it is for, say, a donor bone marrow transplant, where we do try to get people off immunosuppressive drugs.
Yeah, that'll be interesting to kind of study that in addition to potentially immunosuppressive drugs in myeloma, like if you've got a double hit or something like that, because one area of research which is really fascinating is that there has been some discussion about using some of our drugs or our approaches like CAR T. There are people out there who would like to get an organ transplant but have very, very high production of antibodies against other people's tissue types. And that can be a very difficult situation. And so there's been some interest in using myeloma-type drugs to actually treat people before a transplant to bring down those levels as sort of a beneficial effect of some of these anti-myeloma drugs or a CAR T, for example. Wow, that's so fascinating.
Yep.
How do you know that in advance? I mean, is there donor testing that you do?
Right. So for a person who's being considered for a kidney transplant, what they would like to do is they screen you for what are called anti-HLA antibodies or human leukocyte antigen antibodies. So meaning, are you likely to react against other tissue types? And so if you have a very high level of these antibodies, it is very likely that you're going to have a kidney rejection problem, and so there are various maneuvers they can try to do to get those antibody levels down. But it's a big problem in organ transplantation, not just for kidneys, for other organs as well.
Yeah, it makes sense. I'm sure that's a long process and probably not an easy process. Is there like an average time to get on a waiting list to get a new kidney?
It is often in, well, one of the things that makes that time built in is that kidney dysfunction, as opposed to, say, heart dysfunction or liver dysfunction, is something that people can be on dialysis for a period of time. So there is that kind of bias, to say, well, of course you can be on, you can be waiting here. But then there is also some degree of size. So if, for example, a child is needing a kidney, sometimes it can be hard to get a donor for that. Or, like, I'm talking about a very tiny child. The average wait time right now is still about 3 to 5 years. But I think that's why that's been the move to try to find people that are related to you, or people who are friends of yours who might be willing to donate a kidney. So that's, if you've got a person like that, if you've got a living person who is willing to come forward, the wait times are much, much shorter. But of course, not everybody has that situation.
Yeah, that seems tough to time, like the length of your remission around your transplant too, right? That's a tricky balance. And I would say it's looking at the patients that I've had who've undergone kidney transplant. There's a little bit of luck involved in it too. There's also something I didn't mention is they would like to have compatible blood types if they can do it as well. That is one reason why they will certainly ask you if you have somebody who could possibly donate a kidney for you. It's always faster, and as many of your listeners know, there's two kidneys by and large. They do test to make sure there's two if you want to be a donor, and and usually that single kidney, once they remove one for the donation, takes over the work of the two kidneys and does just fine. Yeah, okay. That's great. Well, so I've had certain patients say that only certain centers will perform transplant on them due to the complexity of their myeloma. Like they went to a kidney, like a regular transplant kidney center. They said, oh, sorry, you have these myeloma issues or whatever. You're going to have to go to X facility. Do you hear that a lot? How do you coordinate that kind of care?
We're fortunate here at the University of Wisconsin. We actually have a very large renal transplant program, one of the largest in the country.
Oh, wow.
And so they're pretty experienced with various situations. And so, as I mentioned, their biggest concern is, how well controlled is your myeloma, or for that matter, your amyloidosis. Those are things that they consider. And they tend to work very hard to find donors for people, and I think we've been working together for long enough that I think they're quite comfortable. And so, they'll often say to me, okay, do you think this particular patient, is their myeloma in good enough shape? Could we consider a transplant? And we'll, sometimes have a discussion about, no, maybe they should be on treatment longer, or yes, they're doing great, this would be a good time to consider it. So, I think that's one of the things that's been beneficial here, is we just have a very good relationship with the transplant service, and they're very comfortable with us.
Yeah, I think this is a point I always stress too. It just the idea of having a myeloma specialist on your team that can help coordinate this kind of care, because I would imagine that sometimes even just a handoff from a nephrologist to a transplant center for a kidney transplant is, I've heard, kind of difficult. Like they don't know where they are in the process or whatever.
Right, and I think the other thing is just like you could say, well, I'm going to go see a hematologist. Not every hematologist may do a lot of myeloma. So the same thing goes with kidney doctors, and so some kidney doctors, all they do is transplants. At a large medical center, that's really their thing. They're not only just sending patients for transplant, but managing their care after they go through the transplant. Whereas sometimes, if you're in a smaller, maybe more remote area, the nephrologist you may see is sort of a general nephrologist and may not have those connections to a transplant center, or just may have assumed from maybe if they've trained some years ago, well, if you have a blood cancer like myeloma, of course we would never consider a transplant for you. So I think there is sometimes, particularly, that's a very, very, it's a small subset of people who are thinking about this, but it probably is the kind of situation where you would want to be seen at a real specialty center.
Yeah, well, I think we want to think about that all the time in myeloma as well, just whether we have a kidney issue or not, is finding a specialist like yourself to help with consultations and making treatment decisions and trying to navigate all the complexity of this type of thing. I have one more I have several more questions, but I also want to open it up for caller questions.
Okay.
But in the MGUS or smoldering precursor condition stage, are there things that you suggest to MGUS or smoldering myeloma patients about kidney function, like here's what to watch out for, here's what to do differently, or that type of thing?
I think I have to credit the doctors at Mayo who sort of took the lead on this a number of years ago. So there's an entity that is often abbreviated monoclonal gammopathy of renal significance, or MGRS is the abbreviation. And what that is, these are people who have kidney dysfunction that's significant. But if you start checking their monoclonal protein levels or a bone marrow biopsy, they don't actually make a definition of actual myeloma, but it's pretty clear they fall into that group, as I think I mentioned at the very beginning, this monoclonal immunodeposition disease. That monoclonal protein, there may not be a lot of it, but for reasons that we don't understand, it is specifically targeting the kidney. So these patients don't tend to have anemia, they don't have bone disease, but they will have a creatinine elevation that's quite striking and often have a lot of protein in the urine. So even though you would say, well, they have fewer than 10% plasma cells and they don't have any bone disease, these are people that more and more we're saying that clone of plasma cells is clearly causing a problem, and so they should be treated and in many cases, go through an autologous stem cell transplant, just like if you had a higher level of protein or higher bone marrow involvement. So that's kind of an area that's emerging. And again, I think if you're at a larger center, many people, many nephrologists are very used to thinking about that now. But I think that's an area, if you have MGUS and your creatinine is very elevated, I'm talking about it's more than 1, so let's say it's 1.5 milligrams per deciliter or 2, and you have MGUS, the one thing you'd want to make sure is, hey, I don't have this, I'm not in that subset where that monoclonal protein is really what's causing my kidney dysfunction. And again, this is where a kidney biopsy really comes in, because you can only really make that diagnosis of MGRS with a kidney biopsy.
Oh, that's so interesting. So many things to think about. And again, in my opinion, if you're working with somebody who's just treating hematology generally, or you're in a general oncology community center, that might be tougher to pin down, right? Just because of the time to see it, right? Or
and I think, this is, again, one of those situations where it is always, if you can, if you've got the information at that you can access, to be kind of aware of where things have been, so for example, if you know for sure that I never had kidney dysfunction, ever in my lifetime, and now you tell me I have MGUS, and I have maybe 1.5 grams of protein in my bloodstream, but my kidney dysfunction is, I have a lot of kidney dysfunction, I would say, you need to make sure that those two aren't connected. And again, I really do think, I actually really like it when people come in with notebooks and spreadsheets and things like that. It's usually quite helpful. I mean, people do an amazing job these days of tracking all of their labs, which, like I said, it's just excellent information.
Yeah, no, I mean, we provided the HealthTree Cure Hub tool for that too, because you want to be able to track those main features, and sometimes even like if you have MyChart or something, it's I don't know, it's not the easiest tool to use. It's useful and good. Yeah, but seeing it over time compared to all your other features, it's hard to do.
Yeah, with HealthTree, because I think MyChart, I've found a lot of patients, since we have Epic at our institution, who are quite frustrated with it. They just feel like, well, I can't see enough, months in a row, or I can't see enough
Right.
Years, and it's a little, sometimes not everything gets posted. So using tools like what HealthTree provides is great.
Yeah, wonderful. Okay, my last question: how can myeloma patients protect themselves against kidney disease once they have it and while they have myeloma?
Well, I think some of this is really common sense. So we try to get people to make sure that they're well hydrated. And particularly in the summer, or if you're living in a hot part of the country, we usually tell people we want them to drink, somewhere between 2 to 3 quarts a day. Absolutely, we like people to avoid getting contrast. So, for example, if you are getting a CT scan or a PET CT, we really want to be careful about contrast. That can be hard on the kidneys. We already mentioned things like Aleve and Motrin and Advil. You want to be very careful with that if you know already you have some kidney disease. Let's see, other medicines out there. Like I said, if you get started on a ACE inhibitor or a diuretic, you just want to make sure that somebody's watching your creatinine. People sometimes ask, is there anything specific you can eat to make your kidney function better? I don't know that we really know anything. There are some nephrologists who feel that too much protein is hard on the kidneys. Sometimes they'll try to limit protein below something like 60 grams, which really isn't that much protein in a day. That I think I don't usually tell people that they need to do that. A lot of times I'm more worried that people just make sure that they're eating enough. That sometimes can be an issue. And I think keeping your myeloma well controlled is another big factor in all of this too.
Yeah, wonderful. Okay, well, I want to leave some time for caller questions. So if you have a question for Dr. Callander, you can call 347-637-2631 and press 1 on your keypad. And we'll go with caller who ends with a phone number that ends in 9363. Go ahead with your question.
Hi, yes. I just was wondering if there are any treatments or medicines that can be tried as a last effort to try to recover any kidneys that were damaged as a result from multiple myeloma.
Okay. Yeah, I think,
maybe prior to transplant.
Yeah.
Well, So that is a very interesting question. I think sometimes there are, and one of the things that you'd want to figure out is just what we were addressing earlier. Are you really in remission or not? So if you're in remission, it can be pretty tough to just say, well, I'm going to treat your myeloma more, and that's going to make the difference. But sometimes it really takes a little bit of effort to figure out if that's the case. Recently, some of the patients that we've had who've had some kidney dysfunction turn out to carry in their myeloma cells something called a translocation of 1114, or it's a rearrangement of what's called cyclin D1. And people who have that change in their myeloma cells tend to be fairly susceptible or fairly responsive to a drug called venetoclax. And venetoclax is used widely in lymphoma and chronic lymphocytic leukemia. And in people who have that change, and I've seen some people who've had some pretty significant kidney dysfunction who receive venetoclax often with daratumumab and have had some really excellent responses to that. So I think that's what I would try to figure out first, is whether in remission, and then, are there other agents that haven't been used. But if you are in remission and your kidney function isn't recovering, I don't know that that's going to be helpful. And like I said, sometimes we have had patients go through a repeat kidney biopsy to sort of say what's there. And so if they end up having just scar tissue, I think that tells you, all right, there's really nothing that you can fix, versus if somebody has, say, an active cast nephropathy, or they have this, immunoglobulin deposition, you can say, aha, I'm going to really try to treat somebody to make that better, to make that go away.
Okay, awesome. Thank you.
Okay, thanks. And there are no kidney-specific drugs, right? I mean, so you're talking about treating the myeloma and hoping the kidney can recover, but there's nothing you can really do to treat the kidney.
No, but this is like I said, I think kidney biopsies, which used to be considered, well, that's just so, that's so invasive. I think this is, again, something that can help a person. If you say, I really want to find out whether there's still some kidney that's still able to recover, that can be a very helpful way to figure that out.
Mm-hmm. Okay, great. Okay, and another caller at that ends in 1159. Go ahead with your question.
Hi, Dr. Callander. My question is there a procedure or treatment to unblock the tubes in the kidneys that were damaged by the abnormal myeloma protein?
You know, it except for treating the myeloma and hoping that they recover, no. There's no like sort of roto-rooter or anything like that you can do to sort of flush them out. You know, as I mentioned, sometimes at the beginning people will try, along with just treating the myeloma, a plasmapheresis procedure that's done in some places. But we don't, unfortunately, have a great way to just sort of flush out the kidneys, except for drinking things.
Okay, thank you.
Okay, great. Well, Dr. Callander, I know we're at time, and I just want to thank you so much for doing this show with us. This is an important issue for patients. It's something we hear a lot about in different, venues on social media and in some of the calls that we get and things like that. So I just want to thank you so much for sharing your expertise with us. Yeah, absolutely. Thank you for all you do for patients. Thank you for helping get these drugs approved and just treat patients so incredibly well. So thank you so much for joining today.
Okay.
All right.
Take care, everybody. Thank you for the question.
Appreciate it. Bye-bye. And thank you so much for listening to this episode of Myeloma, the HealthTree podcast for multiple myeloma. We invite you to join us next time to learn more about what's happening in myeloma research and what it means for you.
Step into the world of power, loyalty, and luck.
I'm gonna make him an offer he can't refuse.
With family, cannolis, and spins mean everything.
Now, you wanna get mixed up in the family business.
Introducing The Godfather at ChumbaCasino.com. Test your luck in the shadowy world of The Godfather slot.
Someday, I will call upon you to do a service for me.
Play The Godfather now at ChumbaCasino.com.
Welcome to the family.
VGW Group. No purchase necessary. Void where prohibited by law. See terms and conditions. 18+.